Hello everyone, and welcome to the Centre of Research Excellence in Severe Asthma seminar series. Today we're going to have a seminar presented by Professor Charles Irvin, and it's entitled The Physiological Phenotyping of Airways Responsiveness in Asthma, Implications for Personalised Medicine. Before we get started, I'd like to acknowledge AstraZeneca, who are sponsoring Dr. Irvin's travel to Australia and refreshments, and we thank them for their contributions. Today, this seminar is being presented live, but also online. Time for questions will be at the end of the seminar, and questions will be repeated for the online audience. Online audience members can ask questions by entering them into the question panel at any time during the presentation, and they'll be read out. So I'd like to present our speaker to you, Professor Charles Irvin. He's the Director of the Vermont Lung Centre, Professor of Medicine, Molecular Physiology, Biophysics from the University of Vermont, and his expertise is mechanisms of airways dysfunction of the patient with asthma using a multidisciplinary approach. We're looking forward to an excellent presentation today, followed by questions and an active discussion.
All right. Good morning. Whatever time zone we're in. How long do I have, Steve?
We've got an hour during the session.
Okay, so if about 10 minutes before you wave at me, in case, because this is a kind of a new talk for me and I'm not quite sure about the timing.
No problem.
Right. So we can go back because there was a question. This is not the ocean. The lake is Lake Champlain. It's about 150 miles long from Fort Ticonderoga up to the Richelieu Canal in Canada. Across the lake there are the Adirondack Mountains. And in the foreground is Burlington, Vermont. Yes, we do have a university. Yes, we do have an airport. It's unusual in the sense that this is the main university here. It's one of the oldest universities in the United States. This is the medical school right here, and then our associated hospital. And it's unusual because it's one of the few campuses where they're both localized the same. And it's absolutely lovely, and I hope you'll come and visit us sometime. So this is the title of my talk. And I guess I should really tell you a bit of a story about that and how I kind of got myself ahead of it. Well, that'll develop. First, there's a disclaimer. I'd like to thank AstraZeneca for supporting my trip here. Clearly, everything I say is my fault, not theirs. And then I'm not going to be talking about anything that's off-label, and all the studies I have, or am going to present, were carefully vetted by our steering committees, the IRBs, and those nice people at NIH and our peers. I have some financial relationships with various companies, but nothing of significance really, and nothing that really has anything to do with this presentation. Now, this is just one of the many asthma guidelines that there are. And it's kind of interesting in the sense that when you think about asthma the way I do, which is kind of one patient at a time, from my years of looking at and interpreting lung function of some of the worst asthmatics in the United States at the National Jewish Hospital in Denver. And you look at what they're recommending is first low-dose inhaled corticosteroids, you add a LABA to that, you up the doses of everything, and then you get to step 5, and I call this throwing the kitchen sink. And that doesn't kind of make a lot of sense when you think about it. And then the other impetus for this talk was, some of you know David Chapman, who's been working with me the last couple of years. David sent me an abstract at the recent thoracic meetings here. And the next abstract over was from your group. And I actually thought it was quite interesting, and I want to talk to you what does multidimensional assessment mean? And I think it means the same thing I think it means. And that is that you really have to understand the person that you're dealing with to get any real insight. So at the risk of bringing coals to Newcastle, I always wanted to say that. we'll proceed. So asthma is a common disease. It's a big deal. Prevalence is high. Prevalence of asthma in Vermont is the highest in the United States. It's a major cause of school and work absence. Actually, if you go and talk to a school nurse, you'll find, at least in the United States, 60% of their time is spent with asthmatic kids, which kind of blew me away. And it costs a lot of money. Developing countries, Western countries, and poorly controlled asthma is expensive. And so that's shown here. And, you know, well, I guess this is cheap, $2,000 a year to take care of a mild asthmatic. Seems kind of expensive to me. And then you get into the severe asthmatics, and, you know, from this data, it's about $13,000 a year to take care of these patients. And that's probably an underestimate. And I'm married to a woman who has severe asthma. And I know that the cost of her treatment really exceeds this. So what is asthma? And notice that I say, or is it? Most people, if you ask them, they'll tell you that it's chronic inflammation. It's associated with certain symptoms. And then lastly, the sort of nocturnal early awakenings, and I'll talk more about that down in Sydney tomorrow, but this is what you'll get out of most people. Now, asthma is the most amazing disorder that I can think of, because it's the only chronic disorder of this prevalence that people take care of without measuring anything. Now, if you had a patient with hypertension, you'd measure blood pressure, right? And not to do so would be malpractice. Same thing for diabetes and blood sugar. Yet here's a condition we take care of, and all we do is ask the patients, who are totally unreliable, about what's going on with it. And we treat them accordingly. At least that's what most physicians do. So let's talk about a case. Since I thought this might be a hospital and didn't really know what I was doing here, so I thought, well, let's always start with a case. That's always a good place to start. So this is one of a patient that one of my colleagues in Vermont saw a few years ago. She's a 46-year-old female. She's had asthma since 18. She's a smoker, but not a lot. She's poorly controlled. She has a gastro reflux, basically. Sinusitis, Crohn's disease diagnosed a couple of years prior. She's taking oral steroids. It's always a bad sign. The classic combo, ICS and LABA. This is concerning to me. Nebulizations of albuterol, montelukast, and a variety of other medications that she's tried off and on. In other words, the kitchen sink. Her FEV, I'm a physiologist, so her FEV1 is 54% predicted, which is really horrible. And she gets better with bronchodilators, okay? So this is about what you're gonna get in most places. Actually, for us to have done lung function is a real step forward, because the chances of getting lung function done as an asthmatic runs somewhere less than 50%, probably down in 25, 30%. For a disorder where that's what it's defined by, which is pretty amazing. So with that conflict, what's going on? Why is her FEV1 low here? Why is it still low there? And what's going on in her lung? And how do we best characterize that and, more importantly, treat it? Okay. Now, to really understand this, let's go back in time to when I was a student. When people thought that asthma was a nervous disorder, it made a lot of sense. You have airway smooth muscle that's hyper-responsive, and hyperactivity was really just coming into the forefront at that point in time. And if you imagine a reflex loop that's hyped up, you can get to airways hyperactivity really nicely, okay? There's a problem with this, and the problem is atropine doesn't work as a treatment. People tried for years, and it's interesting to me to see how we're coming back to anticholinergics again. And I suspect with the same kind of success. Now, this is a diagram from a study that I did with Norbert Barron and Peter Henson back in the 80s. What we did was take a complement fragment and put it into the lungs of bunny rabbits and measured airways hyperresponsiveness, because that was the new thing to do at that point, was to be measuring that. And we demonstrated that neutrophils, because C5a disarge, which is what we used right here, is very specific for neutrophils, both in terms of chemotaxis and activation. And it caused what we thought was smooth muscle hyperresponsiveness and increased reactivity. Now, I find this amusing because we got really criticized about this at the time. First, this is one of the first studies that showed inflammation was related to lung dysfunction and characterizing asthma. Well, we got criticized about neutrophils, and so I find it fascinating now how that's come made full circle. And that thus began the age of inflammation, and what I call the search for the Holy Grail. So in the 70s, we thought it was nerves. Then we thought it was inflammation in the 80s. And today, we're talking about subtypes of inflammation, cytokines, and other sorts of things, okay? And we're really entering the era of phenotyping, and this presentation speaks to that. Now, this is the current logic model that most people use with what I would characterize as poor success. And that is, first, everybody's all hepped up about what cell causes asthma. And that depends on who you listen to, all right? It could be the eosinophils made a big comeback. That's what's shown here. And then there are the genetics guys. And don't get me started about the scandal of genetics and asthma. But they think there's a gene that causes asthma. And then there's a mediator, the mediator. And of course, the folks in the private sector are interested in the drug that blocks the mediator and cures the asthma, all right? And this logic diagram doesn't make a lot of sense to me, as I will develop. And I'll come back to it. This is what's really going on. And this is an oversimplification of what's going on. I haven't put half of the things that I could in this diagram, all right? And that's the real problem that we have. Or when we think about the obese asthmatic, is any of this going on? So the basic conclusions that I would draw at this point relative to this aspect of asthma is that the inflammatory process, when present, is very complex and highly variable. I'll be talking a little bit about obesity, but I could also be talking about nocturnal asthma and what's going on there. The substrate is important here, and that includes age, sex, race, which is something that we don't talk about, and then the severity of the disease and its duration are likely to be also important. Okay. But nowhere does anybody really talk about the functioning of the lung. Okay. That's all sort of swept under the table. And if we go back to this diagram, what I just told you, this kind of an approach to treatment, while it's fine, I suppose, as a place to start out in general practice, is certainly not what we would expect out of our referral centers such as here. So in that context, why would anybody expect that asthma therapy would be a one-size-fits-all proposition? Now, the perspective I'm going to bring to you is a series of studies that were executed through a collaborative program that's funded by the American Lung Association called the ACRC. It was originally the Asthma Clinical Research Centers, now the Airways Clinical Research Centers, because we have to embrace other forms of inflammatory lung disease like COPD. And our sponsors, American Lung Association, told us we had to do it. Currently, we had 19 centers. Currently, there are 17 that include 24 trial sites. Our coordinating center at Johns Hopkins. The center that I direct is here in Vermont, and here are my two co-PIs, David Kaminsky and Ann Dixon, and Ann, I believe, has been here. And really, our center is quite unique. It's the only one in the Northeast, interestingly enough, and it's the only one in a rural setting. The rest are in urban settings. Okay. These are the trials that we've finished to date, and I'm going to be talking about several of them. They've all been funded. They've either funded with the core grant or with NIH support, and in some cases, the private sector in a number of different ways. Now, our mission is a little different than most, and that is We spent a lot of time talking about this, and for the young people in the room, you know, when old folks like me get up and start talking about missions, you usually head for the exits, but they actually is important to have a, why am I here? What are we doing? What's the mission of the hospital, of the university, of this institution, so that you can better understand what's important and what isn't. So we talked about it's important that we do trials in diverse populations, and you'll see some examples of that, and try to do things that are practical, okay, and actually improve health, which I think sometimes gets lost in many of the things that I see anyway. So this is our first trial, and you know, you sit in a room and you say, well, geez, what trial should we do? And it was just based on what money we had. And what we really wanted to do was do a flu vaccine study and look at efficacy. But instead, we only had enough money to actually study whether it caused harm or not in terms of safety. Because if you ask asthmatics, geez, I don't want a flu shot, it gives me flu, and my asthma gets worse. Okay? And so what we did with the study is actually pretty interesting. And as you can see, we hit a home run. Our first study was published in the New England Journal, that little society journal down east from us. The objective was to study the safety of the vaccine in children and adults. Notice the diversity there. It was placebo-controlled, double-masked, crossover design. We had 19 centers. Now here's the neat thing about this. To get into this study, all you had to do was two things. Some doctor had to say you had asthma, and you had to have a prescription for an asthma med. Other than that, we took everybody, for the most part. All right? We also recruited, and there's 2,000 patients in this study, and we recruited them in about 6 weeks. Okay? And we did simple stuff. And we're still looking at the data from this study. Now, here's the primary outcome. We developed an endpoint, which we refined in the next study that I'll tell you about in a minute. It's an exacerbation rate, and it has to do with peak flow and beta agonist use and a couple other things that probably don't affect it much. And here's the endpoint. So 3 days after either you got the placebo, which is saline, or the vaccine, and then half of them got the vaccine first, and half of them got placebo first. Okay, and then we studied them for about a month, and then we reversed it. Okay, because we had to do this in a hurry. Now, no effect here of the vaccine versus placebo. No difference here. Now, 2,000 patients. Negative study, great. The vaccine does not cause an asthma worsening. Now, for the young people in the room, this is now the Socratic part of my lecture. What's unusual about this data? Does anybody notice? It looks pretty boring, right? What about the axis on the left? What do you see? Come on. Not you. I said the young people. Come on. We're friends here. You're learning. You can't say wrong things. What's really weird about this? What? You bloody well right there are. Look at this. Within 3 days, the 15% of them are crashing and burning. And within 2 weeks, 30%. No wonder they thought the vaccines made their asthma worse, because their asthma was going to get worse anyway. All right? This was mind-numbing to me. These are good centers, good PIs. They should be taking good care of their patients. And here's the data. 38% of them are having exercise problem once a week. Without exercise, 30% of them. This is the one that blew me away, because we know this means severity. 25% of them are waking up at night with asthma. We're doing a really bad job of taking care of our patients. Okay? That's what this data. There's another study that was done that showed the same thing in the United States. Now, you guys, I'm sure, are doing better here, right? But the point in fact, either the therapies we're doing are ineffective, or the patients aren't taking their meds. Okay, it's probably both. Now, our next study was the one that I designed, and I wanted to study low-dose theophylline. I won't go through the background of that. And then one of my colleagues said, Charlie, compared to what? I said, well, we'll use another oral treatment, because this is an oral one. So we'll use Montelukast. So this is actually a really good example of comparative effectiveness study. Okay. We thought that low-dose theophylline, when added to medications of persistently symptomatic patients, will decrease the total number of exacerbations, and we're going to use a term called EPACs, and that is increased use of bronchodilators, a change in peak flow over a couple of days, and then some other things that actually don't contribute to the endpoint hardly at all. And that we thought it would be equivalent to Montelukast. That was the hypothesis, okay? And what we did is we took pretty much whoever we could find that didn't have some other exclusion criteria. But it included some on steroids and some not, thank God, as it turns out. And here's the primary outcome. So we have EPAC rates, events person years, and they have about 5 of these events per person per year for placebo over a period of 3 months, 6 months, I think this was. And Montelukast reduced that not significantly, and theophylline did nothing. Now, we had taken bets on this about who was going to win, and everybody lost. And it doesn't kind of make any sense, because they're both treatments that should have had some effect. So when you don't see a response, what you do is you resort to rummaging, and that is there something about the patients? Now, our good friend, Dr. Barnes, Professor Barnes, in London, was promulgating the idea that theophylline and steroids were acting in concert through some elaborate genetic mechanism that he dreams up in the middle of the night. And I thought, well, okay, fine. Maybe he's right, except that that doesn't make any sense for this data. Why don't we break it out and look at the patients who were not on steroids at time of randomization? And then we got a very interesting result. So these are the folks that are not on steroids. Not that many of them. There's 35, it turns out, in each group, and kind of even between them. And with Montelukast, that dropped. And with theophylline, it dropped almost to nothing. And just to go back, notice what's going on here. Okay, this data is fascinating. It says that both of these drugs work better if the patient isn't on inhaled steroids. And to my knowledge, this is the only study I know that shows an interaction between asthma therapy that doesn't actually add up. Okay, that they antagonize each other, particularly low-dose theophylline. Right? Low-dose theophylline is a real winner here. Okay. Now, we further broke this out, using multi-regressions, and found out that about 30% of the subjects were black and about 70% white. And Montelukast works in white people. Okay. And if you look at the primary pivotal studies for Montelukast, they're all done in Caucasians. And low-dose theophylline works really well in African Americans, patients with low BMI, and people who were ex-smokers. Okay. Now, if you're a thoughtful person, what does that make low-dose theophylline perfect for? The third world. Okay. And it's a pill, and we know people take pills more. Now, here's a really other interesting finding that Ann Dixon uncovered from this data, and that is that people with normal weight got better on theophylline, and obese actually got worse. And I keep coming back to this data because it says that the obese asthmatic is something really unique. And there's something really bizarre going on in obesity, and I'll develop that theme just a little bit more. So we conclude all kinds of conclusions about how these drugs might work. Their pattern of response was quite different. That's why these comparative effectiveness studies are really very interesting. And that low-dose theophylline has a profound effect of reducing EPACs, not EPACs, spelling error, on patients not on inhaled steroids. And the responders for both treatments had a very distinct phenotype. Okay. Now, our next study was the LOX trial. And this is a classic crash and burn study. So you stabilize the patient on combination therapy, ICS and LABA. You bring their asthma, their control, we were using ACQ in this one, back into the normal range. And then you say, okay, now that I've done that, can I switch them to either keeping them on combination therapy, fluticasone alone, or montelukast alone? Now, when this study was published, there was another study from Italian colleagues who also were studying PRN as you needed inhaled bronchodilators. Now, at first blush, you'd say, well, these are superior, montelukast is kind of a loser, until you look at it from this point of view, that 70% of the patients, once you stabilize them, are fine. They don't get worse. What's going on in these guys? Why are they still, even when they're on, the guideline therapy, they're still getting worse? What's going on with these guys? Whereas most of them, and the Italian study showed that PRN bronchodilator is about the same. Raising some interesting issues about how we prescribe drugs and how patients take them. And a lot of patients, because the drugs are so expensive, are actually taking a PRN and still being effective, et cetera. Okay. Now, then we began a whole series of studies that are total failures that we still managed to get published. And the first one was a study giving a proton pump inhibitor to asthmatic patients who do not have frank GERD, this sort of silent GERD thing, and it was totally negative. Okay, no effect of giving proton pump inhibitors, and that was an important finding, frankly, because it's been long thought that with more difficult patients that GERD's an important player. This suggests it isn't. We then, because we didn't believe it, we did it again, published this one in JAMA in kids, showed no effect, and with the proton pump inhibitor, we actually saw an increased rate of fractures. Then we did a really interesting study because in the CEVA trial, we found that half of the patients are in some sort of complementary alternative medication. So we decided to study soy. There were animal studies that said that this was probably important, and a small pilot project done by the leader, Lou Smith, in Chicago that showed that it was anti-inflammatory, et cetera, et cetera. We did a big trial and saw absolutely no effect. This one still makes me mad. I spent a lot of my career showing the connection between upper airways and lower airways function. And so this was the really moonshot. Let's treat patients with steroids up the nose and show that asthma gets better, and it didn't. And I'm still very unhappy about that because this is, you marry to a hypothesis, right? And it's painful when you lose it, right? And then the recent one we did was with CPAP. And there, again, we had really strong animal data, some very strong pilot project data, and this was a total failure. In fact, the control therapy of wearing CPAP masks with no pressure, essentially, was the most efficacious treatment. So you try writing a discussion for a paper with that finding, okay? Now, more recently, these are all unpublished at the moment. The first one is actually accepted, I believe, provisionally in JACI practice. And that was a navigative study. We've been studying smoking asthmatics as our foray into, dare I say the word, ACOS or ACO, depending on who you listen to. And smoking asthmatics are really interesting people. We don't study them typically. They're at least the group that we just recruited a bunch of them and tried to learn more about them. They're disasters when it comes to taking their medication, and they have a high rate of lawlessness. As you go through each one of the case studies, they're on probation. They didn't show up for their appointment because they're in court, and quite a number of them were wearing ankle bracelet things, tracking things. And they're really hard to recruit, and they don't show up for their appointments. So I'm worried about our plans relative to this group. We did another one where the pediatricians are faced with a kid who comes in and they finally do lung functions on them, and they have fixed airflow limitation. They'll get better with a bronchodilator. Why is that? And it turns out that when we go back, this is all a retrospective record review, a lot of allergies, prematurity, but there's still a lot of unexplained reasons for it. And then I won't talk about our psychology profile in COPD, which was interesting as well. So when we get to this logic diagram, you can already see it starting to fall apart. And I won't go on and talk about the current approaches of trying to target a single cytokine, but you can imagine my thoughts about it. Although you never know. And I think one thing I've learned is moving from the animal lab into doing clinical trials is you cannot predict what you're going to find in the clinic. And that's why I have to actually study it. I think it's also important to keep in mind that asthma and a whole list of other diseases are complex disorders. Okay. Now, I remember when the CF gene was discovered, and oh, everybody said, well, we're going to fix Delta 508 and then life will be good, and they did that quite remarkably, and they still don't see a big effect. And we're involved with all these trials at my center, and now they're looking at combination therapies of genetic recharging the system. And as you get down here, you get into things like environment, multifactorial, and polygenic, which certainly describes asthma. And then when you combine asthma and obesity, you got a real mess on your hands. Okay? And so in that framework, let's talk about obesity and asthma, because I know that's an interest of this center. And when we started our study, this was the prevailing view. That is, you're fat, like I am. Your FRC goes down, like mine is. And then you become hyperactive because you're at a low lung volume. It all has to do with smooth muscle and length tension, which turns out to be totally wrong. It's true acutely, but chronically it isn't. And so our study was, well, let's look at this. This was a project that we did with Ann Dixon, who's now made this into her career in a most remarkable way, I have to say. And our ideas were totally crazy and wrong, as they tended to be lately. And that is that we thought, well, we're going to just see more inflammation in the fat folks. Because everybody knows that, and that was a new thing at that point, that it was becoming increasingly recognized that fat was actually an inflamed organ and lots going on, not just fat. Okay, so we thought we'd see increased inflammation, and maybe that explains the obese asthmatic. And then to do that, you really, if you think about Koch's postulates, right, the most important one, the only one that matters, is if you block this disorder, you can reverse it. So in this case, how are you going to get people to lose weight? How many of you have, well, I've tried many diets, totally hopeless, right? That's a hopeless thing altogether. So, and then patients don't do it, they cheat. So let's look at bariatric surgery. You don't have to worry about adherence. You know when it started, and life is going to be good. Yeah, right. Okay, so this is an interesting group of people, to say the very least. And a style, you know, keep it simple, stupid in terms of clinical designs, the parallel design, normals and asthmatics all having bariatric surgery, and then a number of study visits that go over 12 months. Turned out we kind of blew that. We should have probably studied them at least at the first month, because of some of the things that we have since seen. We found that, as other people have described, that the fatter you are, the lower your PC20, I mean more hyperreactive. Bariatric surgery made that better, but notice that it was highly variable. Okay, as a group, significant, but a lot of variability. And then Anne hit on this idea that's turned out to be gold. And so this group here has normal IgE, okay, Th2 low, if you allow me that term. And this is Th2 high. These are the allergics, non-allergics. The non-allergics get better, and not so much over here. And the reason is kind of complicated, as it turns out. For the allergics, none of these people, by the way, because they're having bariatric surgery, we could do lavage, there are no inflammatory cells. None. Blew me away. Okay. When you lose weight, the cells come back. The T cells and every other cell we've looked at in these fat people do not function normally. Okay, losing weight allows them to regain function, even though you're still obese. Right? Now, the Th2 low ones are an interesting story. Their lung volume may be more important, but we don't get great correlations. And so we're thinking a whole other kind of mechanism here, and I'll let Ann tell you more about that as that story starts to evolve. Now, with David Chapman, who was working with me, we wondered about, is there a functional phenotype that might explain this data? And the idea of it is shown here. This is work he originally did down at the Wilcox in normals, obese, and asthmatics. And I said, well, let's look at obese asthmatics before and after surgery. So you get different phenotypes. So this is a person who has airway narrowing. So here's their FEV1. And the change is explained by changes in FEV1 FVC ratio. In other words, the FVC didn't change and this fell. And you can see the FVC doesn't change too much in this example patient. And at the other end of the experiment, or spectrum, is a person like this who tends to be the morbidly obese, where the ratio doesn't change, and the whole measurement is a change in the FVC. Okay. Now, what's going on in these people is their airways are closing versus airways are narrowing. If you ask the unsuspecting pulmonary trainee why that patient, the patient I showed you, has a low FEV1, invariably they will tell you smooth muscle contracts, airways narrow. And I can show you all the data, which I was doing yesterday. It's all about closure for the most part. Okay. So this is the predominant response. Okay, not this. Now, so what we did is we looked at the Th2 high and low. Now, there are not very many patients because we're losing patients because we don't have complete dose response curve to calculate the slopes. They both lost weight. They're very similar to the larger cohort. Lung function improves, but it's both the FEV1 and FVC because the ratio FEV1 FVC does not change. And then the change in FEV1 as a rate improves, particularly in the Th2 low, which I already shown you. Okay, so this subgroup looks very much like the larger group. This is now the change in FVC as a function of methacholine challenge. And with the high, you don't see much change, and you get a reduction in the Th2 low. And this is shown better here, where here we have this the slope of the FEV1 FVC, no change in the high, no change in the low, no change in the Th2 high, the allergics, and the ones that are changing are the low. Okay, so the reason their reactivity gets better with surgery is they're closing less, at least in the one group and not in the other. Okay. I think the things going on here is that the inflammation is suppressed and is now being activated again, and that's why you basically don't see a change in this group, but I can't quite prove that. Now, remember I told you we did all these other studies, right? Here they are, where we had a lot of methacholine challenge, and this is where you learn something important in one's scientific career, young people. Since I understand this program is about training, you learn to turn lemons into lemonade. Now, we had a whole series of negative studies, but we had a whole boatload of methacholine challenges. So why don't we look at this closing index in the context of close to 1,000 patients, right? Here are all the studies. Here's where they were. This one in particular is good because we did a lot of methacholine challenges. We can look at test, retest variability of that phenotype. All right. Here's the data. Here are the 5 studies we looked at. This is the number of patients that are in there, age, kind of, you know, from this was done in children and then mid-range adults. Mostly females, except in the kids. Okay, where it's mostly males, as you'd expect. BMI, not terribly heavy, but you know, typical American. And then most of them, a number of them are in inhaled steroids. And then between this and this, most of them are on inhaled steroids. Asthma control, we originally were using ACQ, and now we switched over to ACT because we keep getting bills from Elizabeth Juniper about using her questionnaire. And so we've made a change. Their FEV1, none of the FEV1s are particularly bad. If you saw this in the lung function lab, you'd say they're within normal limits. The ratio, except for this group and this group, which are a little bit worse patients, are normal, within the normal range, and they're all twitchy to methacholine, because that's how they get into the study. Okay. Now, this is closing index, and the closing index on average is shown here. And we know that normal, from a couple of smaller studies, one that we did and one that David Chapman did, that normals are less than 0.5. In other words, when the FEV1 falls, half of it's FEV1 and the other half is FVC. Okay? So we're defining anything above 0.5 as tending more towards a closing phenotype. And you can see that most of them are. Okay? And if we break that out into quartiles, so this is below 0.5 and then on above point, these are big closers here. Okay, the big closers are right there. There's the FEV1 falls, although it's not a real big effect. The FVC falls and the ratio doesn't change. Okay, so in these folks that are big closers, they're also closed at rest. And then, but the PC20 doesn't seem to be affected too much by it, all in all. We then said, okay, within that group, what can we learn with multilinear regression? There's a tendency for this to go up with age, but look at the error bars. Okay, it's not statistically significant. If we look at boys versus girls, there's a tendency to be slightly more women or girls, depending on which study, in the closers, but it's not remarkable by any means. And the only thing that really comes out of this is obesity. And obesity does have an effect, although it's, again, not huge. I know that's a pun. So some of them are closing a lot because they are heavy, and others are doing it for I don't know why. Okay? But it's clearly a distinct phenotype. Now, I'm going to now take what I've just told you and put it into this scheme that I got off the web from some unsuspecting person. And I think it's, oh yeah, Boston University, our friends down there. It's some training module. And notice they have what I would call a very nice diagram that explains all of asthma, okay, in a very nice, neat package. And now I'm going to take what we've learned from these studies and overlay that. So there's a trigger factor, or not, as the case may be in the terms of the obese. There's inflammation, or not, as in the case of the obesity person who's obese. I won't develop this for you today, but most people say it's mucus, but I would argue it's also very well explained by just liquid and a loss of surfactant function. I definitely don't think it has anything to do with smooth muscle constriction or hyperconstriction. I think the data for that is not even close to jet lags hitting. It's circumstantial. You'd never be able to convict the smooth muscle in court with the data that these guys have got, frankly. Now this one is kind of interesting in this diagram, swelling of bronchial membranes, which I do believe, okay? Certainly in the mice that's true. Or remodeling, depending on how you define that, maybe. And then they all say narrow passages, but I say no, closure. And then leading to all these symptoms, okay? We did a study years ago with montelukast and showed that the improvement in symptoms is related to lung volumes. And the lung volume improvement is what explains at least the tightness in the chest and wheeze, okay? And so trying to relate some of the symptoms to some of the physiology. As far as I know, that's one of the few studies I ever did that. So the conclusions I would reach, how am I doing on time?
15 minutes.
Oh, perfect. That treating patients in a one-size-fits-all approach, I'm being kind here, frequently doesn't work. Like never, at least in our studies. There are distinct phenotypes that do respond. Fat people, white people, African Americans, et cetera, depending on what treatment you look at. I firmly believe that airway closure, not narrowing, is the most common function. Now, I used to believe it was all about closure, but this latest analysis said there's still a role for narrowing. Don't know what that is exactly. I think all this work has serious implications for the correct scheme, whatever that is. Okay, I still like my diagram with all the stuff going on. I still think that's the correct scheme. And then, if you haven't figured it out by now, this has big implications for treatment. Now, where does precision medicine come into all this? Because that was in the title, right? And that is, so Charlie, right, what do we do? Okay, what do we do? Well, I don't know. I'm in equipoise, which is where you have to be to do any clinical study. Okay? I really like this study from my friend Wendy Moore down at Wake Forest. She did this cluster analysis thing that was published a few years ago in the Blue Journal that is quoted all the time, and I really like this. This is simple. I only need to know 3 things that I know have to be important as a physiologist. One is, what's their baseline FEV1? Is it high or low? How big a response do they have with bronchodilator? And when did the asthma start? Which is an interesting phenotype because it's amazing how well that keeps coming out of studies I keep reading about when did your asthma start and how robust that is when you consider people's recall. And those are the only, you do spirometry, which no one does, and you ask a few questions, and not the usual ones, and you get this cluster analysis. What would happen if we added the FVC to this? Forced oscillation measurements, airways hyperreactivity, the closing index that I've just developed with you, lung volumes, or dare I say it, in a mixed population, the diffusing capacity. Okay, because there's some neat things you can learn from the diffusing capacity. Okay. How would that change how we phenotype the patients and then subsequently treat them? Okay. Wait. There we go. Now let's go back to our patient. And you should learn from this presentation, the one thing I've learned running a lung function lab for all those years is what is the evidence this patient has asthma? If you think of this case that I presented at the beginning of my talk, there is no objective data from that this patient even has asthma. I can think of a number of things they could have, but they're not asthma, right? And if this is all you're going to get from a workup, you're not going to learn much more about it. Or at least that's the thesis that I would promulgate for you. I'd like to acknowledge my colleagues, particularly David Kaminsky, David Chapman, Ann Dixon, all the other PIs of the ACRC group, then their staff, because the people that make clinical research work are the staff. And then first and foremost, all the research participants for giving up their time and coming in for these crazy experiments that we talk about. And that's my house and my transportation vehicle every day from the woods. And you should come and visit. I can't find the picture of Dr. Chapman in his all bundled up in his gear, but he's still complaining about the cold. Otherwise, a wonderful guy. So at this point, I'll answer any of your questions that you might have.
Thank you for a lovely presentation. Anyone got any questions?
Actually, if I might interject, the first people that should be asking questions are the trainees. Very good.
I was also wondering whether, when you've looked at your obese versus non-obese aspect, have you started to look at early onset obese versus late onset?
I mean, somebody like myself who's been obese as far back as I can think of, or people that get obese late in life. Aging is an important thing I didn't really talk about very much, but where does obesity play into that? Now, I will tell you that I had horrible asthma when I was younger, and one of my clinic coordinators wanted to get certified for one of our studies, and I volunteered to do a methacholine check. Totally flatlined it. I don't respond to methacholine anymore. Why is that? Is it because I've gotten old, which is, of course, my thesis, or is it because I've been fat all these years? I don't know. We know zero about the natural history of asthma, I would submit to you. Now, the NIH is happy to pay big bucks to understand the natural history of coronary heart attacks and a whole bunch of other diseases, but they're not willing to invest in the most common chronic disease of children, for instance, asthma. So I don't know the answer to that question. It's a very good one. The rest of you have no questions?
Steve, over here.
I'll come a bit closer to the online audience in here. I wonder if you can speak about your thoughts on randomly controlled trial entry and exclusion criteria.
Oh, yeah.
And how much of that has kind of shaped.
Oh.
Now,
Oh, my God.
I thought it might start a rant.
Oh, boy. Well, so to answer that question, one of my colleagues writes me an email. I don't call on the phone anymore. I should, for a couple of reasons. And said, Charlie, I'd like you to write a book chapter, which I should have run for the exits at that point. What's the book chapter on? Well, it's physiology, big surprise. And it's the physiology of asthma, COPD overlap syndrome. So I thought I knew a lot about it, having run this big lab for all these years, and started reading about it. We know nothing about it. There's like 5 or 6 studies, period. Okay? Yet smoking asthmatics are very common. Okay? Why people who have asthma smoke is beyond me, but they do. And we know nothing about them. That's why the SIVA trial is so interesting, Steve. We took everybody. All right? That's why, and we keep coming back to that study. But you're right, you get into some of these trials with some of the inclusion, exclusion, and you wonder what we're studying. Okay? And then on that, you overlay the fact, what is the personality type of the person who actually volunteers for a study? Right? And I can see some heads. Oh, yeah. And you want really crazy people study nocturnal asthma. Those folks are really crazy. Okay? And that's what I learned at National Jewish was the psychology of the patient with chronic disease, and how does that fit into this that we don't even consider. So you're right. That's why when we started our studies, they had us read a paper by, I'm going to probably pronounce this name wrong, Pito from London. Anyway, he wrote these things about simple trials, doing really large trials, simple endpoints, and taking everybody. And so when you go to that study and you compare it to our bariatric surgery study, the two ends of the spectrum. And I think that we know a lot about how to treat asthma for the folks that show up for trials, and not so much about the patients coming into the GPs. Now, if we give them guideline therapy and they get better and they don't bother the doctor anymore, then we're good. But what about the ones that, 20, 30% of them that doesn't work for? Then what do you do? And the guidelines give a very clear picture. We don't know what we're going to do. Okay. It depends on which expert you talk to. None of you trainees have any other? Yes, thank you.
I was curious about the inflammation in the obese.
Yeah.
You were mentioning that there wasn't much inflammation.
There wasn't any in the lavage using classic criteria.
So no
I don't know that, and I haven't been following. Whoops.
Sorry.
I haven't been following it real well about sputum.
Yeah.
And sputum's got some problems too, because normals have 50% neutrophils, and everybody ignores that, but we won't dwell on that too much. And then there's some evidence that I understand that even though those cells don't transmigrate into the lavageable or sputum space, they're still in the lung. They're in the wall, is apparently the latest finding on that. And why is that? I don't understand it. It's been a puzzle from the very beginning. We thought it was going to be simple, right? Well, it isn't.
Obesity-related asthma will be controlled, especially in K2 low. K2 low.
Right.
As patient after the biphasic surgery.
Yeah.
And the reason maybe after the surgery, the people improve their airway narrow, improve their chest capacity.
Yeah.
Or improve the total volume.
Yeah.
I want to ask, do you think any other reasons that originated from adipose tissue?
Right.
Yeah, there are hormones such as leptin.
Right. Well,
leptin.
Right.
Yeah, there are also other reasons. If we can explain that mechanism, maybe we can seek for another target for treatment.
Yep. Excellent question. What do I think? I think a lot about it. So the question is, in the Th2 low, they're getting better because of lung volume changes. Probably not. Probably not. What about leptin? We showed that visceral leptin, not subcutaneous leptin, was related to airways hyperactivity. Why is that? Is it just a measure, because we know that visceral fat and subcutaneous fat are very different, and it's hard to get. So if I asked any obese person, can I have some of your fat, they're happy to give it to you until you say, I've got to crack your chest open so I can get the visceral stuff. Not so much. Okay. So the other finding of that study is that the ACQ, asthma control, got better really quickly, long before you lose weight. So is this part of the metabolic syndrome? Is this a change in the microbiome because of the surgery? Don't know. I don't think it's as simple as just lung volume. I really don't. I'd like to, because I'm a physiologist, but I don't think so. I think it's much more complicated. And that's why this is a good group to study. There are a lot of them, and we need to learn more about them.
If any possibility, we created the fatty asthma animal models.
Oh, yeah.
And we found some targets and maybe seek for some new drug targets.
Yeah.
And do some clinical trials.
Yep. Okay. So the answer to that, that makes sense. We can do a bunch of animal models, and our guys are doing some great ones. High-fat diet, genetic models. They've even mastered making the animals fat and then doing bariatric surgery on them, although they're mice, so they're a little different. And the results are fascinating, and you can read those papers. I won't talk about that. The chances but it gets back to, well, geez, we need to develop new drugs to treat patients with COPD. Why don't we just have them quit smoking? And maybe what we should do is concentrate on techniques that will get them to quit smoking, that work, because the ones we do don't work. Although there's another group in Vermont that's having real success with incentive therapy. So with that in mind, Anne has just been funded by the NIH to do 2 studies with weight loss, one using a drug and the other using incentive therapy. In other words, if you lose weight, I'll pay you. Okay? If you lose a pound, I'll give you $50. And then if you go along and backslide, you have to start all over again. That's this incentive treatment. So stay tuned. Is there a drug? Because the drug we're going to use is one that was used for something else, but we think it might work. And one of the things it does is cause weight you lose weight with it. That's one of its known side effects. Although we're going to use a side effect to its advantage in this case. And it'll be a comparative effectiveness study, drug versus this incentive therapy. Now the incentive therapy has been, like I said, developed by our colleagues in Vermont, very successful. They've used it for smoking cessation with higher success than everything else that anybody's ever tried. They've also then applied it to weight loss with considerable success. So we'll see what happens with that. Okay. Because people that qualify for bariatric surgery you have to be so obese, and it's interesting, only women, for the most part, go through the surgery, not men. So that's the one. So what happens if we lose weight? And maybe drugs aren't always the right answer for everything. Convenient, and that's of course what the patients want, but as you know, hey doc, give me a pill and make me better. Questions? Any questions online?
No questions online.
No, none of our online viewers. They were so irritated they left.
You convinced them.
I convinced them. Well, thank you for signing in, the World Wide Web. Any other questions? Thank you for your attention. I really appreciate the opportunity to speak.